Now we'll transition to our diagnosis section.
Our diagnosis section will include a discussion of imaging as it relates to pneumonia, and then a lot about the bugs, figuring out the microbiome and the blood tests that can help us.
And what would pneumonia diagnosis be without talking about the wonderful world of chest x-rays? So, on this first page, we'll quickly review the lobes of the lung. So here you're looking at anterior-posterior as well as lateral views of just the right lung. So the important things to keep in mind here are that the right, lower, middle, and upper lung lobes are not just stacked like a sandwich. They actually overlap each other in the anterior-posterior direction as well. So that if you look at that bottom left image, the right lower lobe actually comes up 2/3 of the way on an AP view. But meanwhile, the upper lobe is kind of hanging over the front of it and overlapping. The lateral view is really helpful here because you see that that right lower lobe, in the second from the bottom left, is really working its way up the back pretty high, while in the front, the upper and middle lobes are hanging down over it. And so also keep in mind when you look at the top right images there, on the AP view, you'll see that the right middle lobe basically hangs over most of the lower half of the right lung field, and it just kind of spares that edge of the diaphragm at the bottom, but that it does encroach on the right cardiac border, and that'll be important. And on the lateral view, you see that the right middle lobe forms that wedge shape in the anterior and inferior aspect of the chest. And then when we talk about the left lung, we know that the left does not have a middle lobe. It has a lingula, which sort of gets lumped in most cases with the upper lobe. And so then it makes sense, right, that in the top right image you see the left upper lobe taking up what in the right side would have been the upper and middle lobe. And similarly, if you look at that top left image, wow, it's called the left upper lobe, but it's covering almost the entire lung field. So there's a lot of anterior-posterior overlap that makes it less obvious than just one's on top of the other. And then the left lower lobe, you see that it's pretty similar to the right lower lobe as far as coming up 2/3 of the way from the diaphragm up to the apices, and then on the lateral that it forms that wedge shape that continues up the back. So now let's take a look at some pneumonia consolidations on X-ray and see if we can localize what lobe we're talking about based on what we just spoke of. Okay, so first I'm showing you just the AP view here. Where's the pneumonia? So remember, it's taking up the lower half of the right lung field. And if you notice, which is it obscuring more, the cardiac border or the diaphragm? Which is more clear, which is not? That's right, the diaphragm is still clear along that edge, while the cardiac border is being obscured, making this most likely a right middle lobe pneumonia. And if we look at the lateral, we see that classic wedge shape that we saw earlier. Great, let's try another. What about this one? So this time I'll show you both. And we see that on the image on the left, you have an AP view, and you see this whiting out of the left lower corner there. And this time we're having some trouble seeing the diaphragm. And then you look at the lateral and you say, well, it's not taking up that whole giant area of the right lower lobe, but it is, the territory it's filling is definitely part of what the right lower lobe takes up. And so if we fill in yellow the right lower lobe, you'll see that what we're seeing here is just one segment, the anterior segment of the right lower lobe with a consolidation. All right, how about another? Be careful on this one. Okay. So what do we have here? So there's this opacity that's kind of in the, I don't know, that location is kind of where some of the lobes overlap in the AP direction, right? Maybe middle lobe, maybe lower lobe. Then you look at the lateral, and well, on the lateral, is that in the middle lobe territory or the lower lobe territory? Yeah, it's in the lower lobe territory, so maybe this is another segment. Right, there's our full area of the right lower lobe on those views. And so this is found in another segment, the posterior segment of the right lower lobe. Okay, we're getting subtler and subtler. But looking at the AP view on the left, let's use the strategy of bouncing back and forth, right to left between those rib spaces, and seeing where things look different. Sure enough, we find a bit of increased haziness on the patient's left side, and while it's near the cardiac border, it does not efface the cardiac border. You see that? That left cardiac edge stays nice and crisp. And when we check out the lateral, we can convince ourselves sufficiently that this consolidation is in the anterior segment of the left lower lobe. Another important chest X-ray finding to be aware of and practice looking for is called the air bronchogram. The concept is very simple. You have these tubes, your bronchioles, bronchi, that are filled with air, right? So they should be dark and lucent on the X-ray, versus the junk and the consolidation should be really dense and more white on the X-ray. And so if you see these things that are like tree branches or tunnels or like an ant farm going through the consolidated area, and so you can sound smart and say, yep, I see these air bronchograms within the consolidated left lower lobe or what have you. And then the last thing I'll say about chest X-rays is that I feel like every time I was taught about chest X-rays, you'd kind of get fatigued and zoned out by the time they taught you anything of use about the lateral films. And so people get very comfortable with AP and not lateral. And so what I want you to focus on for today as far as lateral films is, first of all, the just general territories, the way I showed you on the previous slides. And then the only other specific sign I want you to think about is the spine sign. And this is basically just, you get the chest X-ray, you're looking for pneumonia, you go to the lateral film, and you just work your eye down the vertebrae from top to bottom. And the general rule in a healthy lung is that it should get more and more lucent. But if you look at this image, for example, you work your way down, and then boom, you hit this whited out area near the bottom. And so that's just another way of saying, yeah, I think there's something abnormal there, because the vertebrae are not becoming more and more progressively lucent without interruption. And when we bring up the AP view for this left lower lobe posterior segment pneumonia, we see that it would have been pretty tough to think much of that little smudge in the absence of the more compelling lateral view. Got it? So for lateral films, just know the territories and look for the spine sign. So the next important piece of diagnosis is going to be thinking about what organisms might be implicated in the pneumonia. So for this, we're going to talk about the EPIC study, which was very helpful. Basically, they were able to take a large number of successive pneumonias and do all the microbiologic tests to try to identify viruses and bacteria that might be present. So the recent EPIC study was really useful because it gave us a better look than we've had before at really what bugs are found and what prevalence in the setting of pneumonia. So you can see from the pie chart that this whole side on the left, 62%, they never found an organism with the usual microbiological testing we typically do in the hospital. Then among the others, viral infection was the most common, and then bacterial, and then some mix in between. Among bacterial pneumonias, strep pneumo is number one by far. The runner-ups, you have your Mycoplasma, which is going to be your most popular atypical bacterium, and then Staph aureus is becoming a growingly important entity. So those will be your distant second and third place winners for bacteria.
So now we've established that in the cases where you do identify a bacterial organism, strep pneumo is going to be your most common. So now we have to ask the question, okay, well, if we're thinking about a typical strep pneumo bacterial pneumonia, are there certain factors that increase our concern for a more resistant organism that may not respond to our usual antibiotics? Sure. And that list is as follows: age greater than 65, recent antibiotic use, alcoholism, medical comorbidities, immunosuppressive illness or therapy, and exposure to a child in daycare. And you might feel like these risk factors are kind of no-brainers and a bit intuitive, and you'll also see as we go forward that they'll be pretty similar to some of our risk factors for resistant organisms in general as well.
Next, I want to put a little spotlight on the bacterium Mycoplasma, because it's the most common of the atypicals, as we saw from the EPIC study, and there are some specific implications to it. So, first of all, it's this weird bug. It's very small. It's one of the smallest bacteria. It actually can go intracellularly inside lung tissue in humans, as well as being extracellular, and that makes it tougher to kill. It can hang around for a long time. Because it goes intracellular then back out again, it actually has human cholesterol in its cell membrane, so it has these unique membrane features that aren't present in other organisms. And it does not have a cell wall. So if you think about all those antibiotics we're using for, say, strep pneumo, like the beta-lactams that are targeting cell wall components, those really aren't going to work in Mycoplasma. And in fact, because it's intracellular and it's such a weird organism, its immune response is almost more like a viral immune response. So if we watch this animated video, we'll see the Mycoplasma come down and stick to the alveolar surface. This is not to scale, mind you. The bacteria would be much smaller. And then the T cell comes down and creates the immune response. And then that's going to create more of a thin, runny, and scant sputum, like we talked about earlier, instead of a mucopurulent sputum. And this is what gives us the term walking pneumonia, because these people have this nagging, dry cough that can last longer, be harder to treat, and just won't act like a typical pneumonia. And then they also have these other interesting features. So Mycoplasma can also cause cold agglutinins, where the antibodies to it will cross-react in cold temperatures and cause hemolytic anemia, and will also cause a Raynaud's-like phenomenon. And so you will get patients in the hospital, I know I've seen some already, where they will actually come in with pneumonia plus hemolytic anemia and maybe even that symptom of the cold fingers, and you'll be able to astutely suspect Mycoplasma and treat accordingly. Okay, so that was a spotlight on a few organisms, and we'll touch on a few more organisms in the treatment section because I thought they're so tightly coupled to the antibiotics that I wanted to talk about them there. But in the meantime, as far as characterizing the pneumonia, these terms have sort of changed over the years, and for the purposes of this presentation, we're really focusing on CAP, or community-acquired pneumonias. There are hospital and ventilator-associated pneumonias, which I'm trying to not emphasize in this talk. There was this entity called HCAP, which is healthcare-associated pneumonia. However, recent guidelines from the IDSA and other organizations seem to be shifting away from this general HCAP term and instead just talking about resistant organism risk factors, which will sort of get at the same thing. So what are those risk factors for resistant bugs? Well, like I mentioned before, they're going to kind of overlap with what I said were the risk factors for resistant strep pneumo. So you have people who have recently received other antimicrobials. You have people with medical comorbidities, represented by the long problem list there. You have people with impaired functional status, and then severity of illness. So if they're sicker, you might be more inclined to treat for these unique resistant bugs.
Another question that often arises is whether to cover for aspiration pneumonia. The trick is that we are actually always aspirating all the time, little bits of saliva, a little bit of gastric contents even. But when people are posing this question, what they're asking is, was there a clinically significant event of aspiration from one of those places that led to the seeding of the lung with a particular organism that affects our management? So really think of it that way. To discuss this more, I would like to paint a picture of what's happening with bacteria in the oropharynx and lung. Until recently, we had this old theory that the lung, represented by this desert on the right side of the landscape, was a sterile space with no growth. Meanwhile, the oropharynx was this dense, dirty place with all this biodiversity represented by these different plants. However, recently, we're understanding that there's this lung microbiome, which is pretty much contiguous with the oropharynx with similar organisms, just in lower density. So I created this gradation from the grassland to the desert. In that context, our typical pneumonias can be thought of as an overgrowth of one of these species down in the lung, represented here. The thing about anaerobic bacteria, which are one of the main concerns in treating an aspiration pneumonia in particular, is that they're pretty slow growing and they require more of a comfortable environment to set up shop. So that said, even if someone does aspirate, they may still end up with a pneumonia secondary to a more typical organism. Also, keep in mind, if you do just a normal sputum culture on these people, they're going to still grow some of those normal flora and not necessarily reveal to you the pathogenic anaerobe down below. That said, in the setting of impaired cough or altered mental status or the aspiration of gastric contents, so there's acid irritation, all these things can predispose the formation of an oasis, represented here, where you have some area that anaerobes have time to slowly get in there and grow and set up shop and create this anaerobic infection. But it's a pretty difficult process to do and only happens in certain people. And, as an aside, Poor dentition is a major reason that someone would have a higher burden of anaerobe bacteria laying in wait in their oropharynx, waiting to cause trouble. All that said, what I want you to take away from this is that especially in people coming in from the community, it's going to be a very selective subset of people who have the right risk factors to allow that oasis to form and then for these unusual organisms to have time to grow in that oasis. Other tip-offs to the need to cover for anaerobes that may be beyond the scope of this presentation might include the findings of cavity, abscess, or foreign body on lung imaging.
So fishing for bugs. So moving on with the diagnosis section here, we want to know what are the various tests that we can use to give us a good guess, if not a sure answer, of what organism is at play here. And so we have the cute little coccyne chains getting caught in the petri dish there. Well, some of the tests at our disposal include the sputum culture, the MRSA swab, viral DFA and PCR, urine strep pneumoantigen, urine Legionella antigen, and blood culture. Now, you don't want to feel like as a knee-jerk reaction you're going to order all of these tests every time. There should be sort of a logic to it. And so while there's not great evidence, there are some guidelines and recommendations which I'll try to elucidate going forward. So one way I thought it would be easy to remember is two scenarios where you order a lot of these major tests is if they're in the ICU or if the patient has an issue with alcohol use. So if someone is in the ICU or uses a lot of alcohol, that's going to really prompt you to get a sputum culture, get a blood culture, and check a urine pneumococcal antigen test. It will also involve doing a MRSA swab, and this we'll talk about in more detail later in our Staph aureus section. But you see I gave you that little logo there to remember this, which is the little telemetry sign with the liquor bottle built into the QRS complex. There are further guidelines that will tell you when other specific times to use these different microbiological tests, such as what to do if there's a cavitary lesion, if there's leukopenia, chronic liver disease, and these can all be looked up on your typical medical guideline websites. Another quick tip I'll give you is I'll summarize when to use the urine strep pneumoantigen based on expert recommendations from up to date. They suggested that being in the ICU, like we mentioned, alcohol use, like we mentioned, also failure of outpatient therapy, leukopenia, chronic liver disease, asplenia, and the presence of pleural effusion, that all of those would suggest getting a urine strep pneumoantigen. Meanwhile, the other reasons for blood cultures besides the ICU or active alcohol use include, again, chronic liver disease, again, asplenia, cavitary infiltrates, and a positive pneumococcal urine antigen test. And that probably makes sense because strep pneumo is actually a pretty sticky bug, and so you have to worry that if someone has a strep pneumonia and they don't have the best immune system, they might be at risk for meningitis, polyarticular septic arthritis, and other comorbidities. Now let's say a word or two about some people's favorite and some people's least favorite lab test, the Procalcitonin. Okay, here's the scoop on Procalcitonin. In principle, in the setting of a bacterial infection in the body, multiple tissues will secrete Procalcitonin as part of the immune response. However, in the setting of a viral infection, interferon gamma is released, which is an inhibitor or downregulator of Procalcitonin. Sounds great, right? Well, how does it stack up in actual clinical use? So far, most trials for clinically stable pneumonia patients say, well, you check the Procalcitonin, they have pneumonia, but they're looking okay, they've been on antibiotics. If that number is less than 0.25, yeah, there's a recommendation to discontinue antibiotics. And then if the Procal is less than 0.1, then it's a strong recommendation to discontinue antibiotics. So studies are showing that in the setting specifically of clinically stable pneumonia patients in the hospital, it is appropriate to use Procalcitonin to help guide the duration of your therapy.